So a very warm welcome to everybody who is attending tonight. Thank you very much for your time and for your interest in our webinar on how to manage UTIs or urinary tract infections at home without antibiotics. Next slide. My name is Lindsay Shahim. A little bit of background on who New Angle is. New Angle is a South African medical distributor and manufacturer, and we have three main focus areas in medicine, being aesthetics, wound care, and medical urology. In our medical urology business, we represent Coloplast in both in-hospital and out-of-hospital products, for example, Foley catheters, balloon catheters, and other products used in the operating room and in different areas of the hospital. Some of you know the Coloplast Speedy Cath, which is distributed by our sister company, Coloplast in South Africa. In our wound care business, we represent Sonoma, which has the product in its range called Microdox, which is used for bladder rinse, and Microdicin, which is used for wound care. Next slide, please. With gratitude, I'd like to thank our presenters for giving us their time and expertise to share insights and advice tonight with us. I will introduce each presenter as we go through the flow of the evening. And at the end of the evening, we will have a time for questions and answers. So please, if you have any questions, you're welcome to add it into the comments, or you're welcome to wait until the end and ask. But it would be easier if you can put it into the chat. Thank you very much. Next slide. So tonight we are going to focus on the why and the how of Microdox bladder rinse, which can assist people suffering from acute and chronic urinary tract infections. Microdox replicates a natural mechanism against pathogens. Foreign substances are removed and destroyed by a natural, non-antibiotic physical process, and Microdox is non-cytotoxic and non-irritating. I've got a short video just to show you the technology of Microdox, which is called Microcin technology. You can watch, it's a very short video.
A relentless passion for healing has driven us to where we are today. Back in 2004, Sonoma Pharmaceuticals was the first company to introduce a revolutionary stable patented hypochlorous acid-based formulation in a bottle, Microcin technology. Its main ingredient, the HOCl, is similar to the natural hypochlorous compound produced by the human body's immune system to eradicate foreign pathogens. The result is a non-irritating, non-toxic, and environmentally friendly liquid or gel without any chemicals, no side effects, or contraindications. It's been proven to have a triple mode of action: antimicrobial, anti-inflammatory, and regenerative, resulting in solutions that work naturally for every body that you can utilize as often as you need for wound care, dermatology discomforts, oral, nasal, or eye care, personal decontamination, surface disinfectant, and animal care. In a few words, Microcin technology is scientifically approved and supported by over 100 clinical papers. Since its launch to the market, our Microcin-based family of products has obtained over 80 regulatory approvals. We currently ship to over 50 countries from its manufacturing facility in Guadalajara, Mexico. Over 40 partners around the world distribute our products. We have obtained over 60 treatment, methods, and formulation patents. We are Sonoma. We change lives for the better.
That we're going to speak about now. And those three main properties is that it eradicates biofilm, it relieves inflammation, and it restores healthy tissue. The Sonoma range is all based on Microcin technology, and the different products are Microdox, which is the bladder rinse product, hydrogel and solution, which we use for wound care, Epicin for scar line and suture line management, and Sinudox for sinus rinsing. I would like to introduce our very first speaker tonight. Next slide, please. I'd like to introduce our first speaker tonight. Ari is, I think, extremely well known to a lot of people in the audience today, and I really have the great pleasure to introduce Ari. He is the former CEO of the Podpara Association for South Africa and one of the leading advocates for the rights of people with disabilities. Ari serves on the presidential working groups on disability, and he's done a lot of help. He's done a lot with Coloplast, gaining access to health projects with rehab doctors and other health clinicians, improving bladder and bowel management, setting guidelines, and ensuring gold standard protocols. Ari is a quadriplegic now of, I think it's 40 years, and thank you very much for your time tonight, Ari.
Thank you. Am I good to go?
Yes, you are good to go. Thank you.
All right, Lindsay, thank you so much. And to the New Angle team, thanks for thinking of inviting me to more this evening to tell a story on behalf of the consumer group of intermittent catheterization, and how I got to meet this bottle of Microdoc 60, which did certainly change my life and is certainly now part of my, it's in my bathroom, it's part of my ammo belt in terms of managing my bladder to make sure that it's healthy and I'm infection free. But I'd like to start this discussion by just telling you a story. And I know I've seen a lot of people that are online this evening, and I've got some great friends and colleagues that I'm speaking to. So I'm humbled, but it's a great privilege for me. So let me tell you my story. I broke my neck in a diving accident in 1985. So as Lindsay said, I'm now in my 40th year as a C5 quadriplegic. You know, of course, many of us right in the beginning, we came into it through trauma, and we did anything to try and walk again. And in my case, it didn't happen. We sought that elusive erection, and could we be sexually active again? Well, I'm not going to continue on that discussion, but I'm just explaining the mindset that we were in. And we had no idea about the unintended consequences of spinal cord injury. And that's what I want to talk about this evening. Until discharge. And only when you get home do you realize, wow, the real battle with being able to integrate yourself, socialize again, possibly get back into an working environment again, is you really need to manage your bowel and your bladder. Of course, your head too. Get your head in the right space. But you're taught in rehab how to navigate your wheelchair, how to use a wheelchair, how to maintain a wheelchair, etc. But the unintended consequences is what damages your confidence and keeps you at home or even in bed. And that was the time when it's not about the wheelchair anymore, it's about your bowel and your bladder. And let me share a little bit about my bladder history, my bladder management history. And it might resonate with some of you here, and I'm sure it will. I started off knowing nothing about bladder management. And so I was connected to this Poles tubing or a condom catheter. And a lot of people still use that method now. And then I was getting a lot of infections. And I wasn't managing this myself very well. Am I back online again, Lindsay?
Ari, I think you've pressed mute.
Oh, no, I didn't.
Now you're back. Now you're back.
Okay.
Now you're back.
Thank you. Sorry to have lost a bit of momentum. But
no worries.
And then I saw a urologist, this is many, many years ago, I mean, 3 decades ago, who suggested you use a Fuji cath and you reuse it all the time, emptying your bladder, and about every 6 months, I would change the Fuji cath. So this was a reusable catheter kept in its own container, or eventually kept it in a Tupperware. And once again, lots of bladder infections. I almost thought this was just part of the package. Always beads of sweat on my forehead, a slight headache all the time, feeling uncomfortable, a little bit of smell in my urine, And I just couldn't believe that this was going to be, the journey of bladder management. Then thank goodness I got introduced to EasyCath by Coloplast, and as they then developed a new product called SpeedyCath, and I found exactly what I was looking for. Self-lubricating. This is a single-use hydrophilic self-lubricated catheter, and I'd found my solution to managing my bladder without infection. So I believe I had conquered the unintended consequences of spinal cord injury, the most important one, and that is managing my bladder. I have been infection-free for a long time, and occasionally, yes, I have had an infection and looked for, and very, very occasionally, looked for, was it the type of gloves I was using? Were they sterile or not? Were my hands clean, or my care attendants' hygiene? I was looking at what are the reasons why I am feeling a bit woozy or not feeling great about my bladder. And this seldom happens, but I was trying to avoid pathology, having a swab taken and then going and taking medication, and going through that period of 5 to 10 days where you not feeling great, and then you spend the money on the pathology and the medication to get your bladder back working as it should do. I was introduced to Microdox 60 by having a slight infection from a great urologist in the George area, and I then got to know the details of bladder wash, and which something that I remember years ago in rehab, they used to use bladder wash, and I thought, oh, well, I've got rid of that, thank goodness. But in fact, now it really is the secret to my bladder, to being having a healthy bladder, besides not reusing catheters, is I've got used to now a bladder wash routine. I'm infection-free. There's no pathology. There's no smell. I'm confident. And so, as I said right in the beginning, and my last sort of statement, which I would recommend to anybody, especially if you're doing intermittent catheterization, is that Microdox 60 has really got to be part of your ammo belt. If you're doing intermittent catheterization. Of course, there are people that are not doing intermittent catheterization but have possibly, let's say, an indwelling catheter. There's no reason why you can't use the same methodology with Microdox 60 and manage your bladder accordingly, and stay healthy. So it's a discovery I made 39 years after my injury, only recently. I'm absolutely thrilled about the outcome. It's economical for me to use, and I now have a weekly routine where I give my bladder a good washout, just for maintenance purposes, and I stay with single-use catheter, SpeedyCath, and thank goodness for that. It's a great, great product. I recommend it, but it's not only a standalone routine. It comes with, so I've got my SpeedyCath that I use 4, 5, 6 times a day, and I've got my Microdox that I use to give my bladder a washout. I'm sure the good Doc V and the other urologist speaking this evening will give all the lowdown on how and when to use Microdox, but it's been a revelation for me. I swear by it now, and it's part of my weekly routine to use Microdox. So just so sorry that it's taken all these years for me to discover that bladder wash is a great thing. I do need assistance, and so my caregiver is well versed in this, and it's easy procedure to do. It's not difficult at all. In fact, I don't think you need any intervention or nursing help as to how to get it done, but it's changed the way my bladder behaves. It's got rid of that small little headache, and it's kept me away from always having to send to get pathology done and having to take a course of 5 to 10 days of whatever medication is specified to me. So I'm really just speaking, not with my titles, but I'm speaking with my experience in my 40th year. So well done, New Angle, for getting that product on your product list. And it's reasonably affordable. And certainly let me tell you, if you work out the cost of a bladder infection, plus the risk if you have to be hospitalized, and the risk thereafter while you're in hospital of possibly getting pressure sores or a hospital bug, a single-use catheter, if that's the way you go with intermittent catheterization, add Microdoc 60 to your ammo belt, and I think your journey is going to be plain sailing. So
thank you very much.
I'm going to stay on board, Lindsay, listen to the conversation
please.
and then take any questions.
Yes.
But certainly I'm not the expert. I'm just a consumer, giving my thumbs up to this wonderful product of yours. So there we go, guys.
That's fantastic.
Thank you so much.
Thank you so very much, Ari. Much appreciated. And thank you very much for your personal experience and your personal history of your journey, which has obviously been a long journey now. And congratulations to you for what you've achieved in this time. Thank you very much, Ari. And Ari will be part of the Q&A at the end of the meeting if you have any questions for him. I'd like to go on to my next slide, please, and introduce Dr. Wilson, who will be talking next. Dr. Wilson, thank you very much for your time. I know it's very valuable. Dr. Wilson is a physician who has a special interest in rehabilitation medicine and works at Netcare Rehab in Johannesburg and has done, I think it's for 24 years now, Dr. Wilson, if I'm correct. Dr. Wilson is very well known and very respected in the industry and amongst the community, and she often presents and shares her very valuable knowledge. So thank you, Dr. Wilson. I'll hand over to you.
Thank you very much, Lindsay.
Pleasure.
Good evening, everybody. Thanks for the introduction, Lindsay. It's really nice to see some familiar names and faces. And Ari, thank you, as always, for your very frank and straightforward advice. It's not really a talk, it's your advice to fellow spinal cord injured persons. So I'd entitled this, with a gentle nudge from Lindsay, Microdocs in My Practice. And like Ari, I was introduced to this only relatively recently, and I wish it had been around in my last 24 years trudging on the wards. Can I have the next slide, please? So, thanks, Dylan. So just so that everybody, I know not everybody here is in the medical profession, not everybody attending is in the medical profession. So just so that you know what we are talking about, we have oxygenated blood coming from the heart. It's the red one going to your left kidney and your right kidney. And the kidneys are essentially like a filtration system. They take out all the, let's call them toxins in your bloodstream and filter it and then send it back down via the ureters, which are the long thin tubes that go down the back of your abdomen, into your bladder, which is essentially a muscle, a very well-controlled muscle, and then out through the urethra, and then obviously the blood that has used up its oxygen goes back in this big vessel back to your heart to get more oxygen from the lungs. The reason I put this up is particularly to emphasize as well, although this diagram doesn't show it, ladies have an advantage over men. They have a nice short urethra, which is easy to catheterize and straight. And the male urethra kind of, I'm going to draw it with my pointer, kind of goes like that, because it has a curved course, and it goes through the prostate gland before it reaches into the bladder. So that makes it more complicated for the men. However, they have an advantage because they can see where they're going. And I always joke and say that's the only advantage to being a man. So it's harder for a woman to learn to catheterize, but once they've done it, I would say 99.9% do not look back. Next slide. So I thought it was important, because of what I'm going to talk about, to just give you an idea of the pH scale. Most of us probably remember learning about this in biology classes at school if we are not in the medical field. And what's important to know is that the normal pH of urine is about 4.8, so somewhere just between 4 and 5, to about 7, just bordering on 8. So that's your normal pH of your urine. Now, bacteria are interesting in a bladder that doesn't empty by itself and requires some other means to empty it, because they settle there. And I'll talk about it a bit more. But what they don't like is they don't like an acidic environment. You're not going to go to battery acid, but they don't like lemons and tomatoes and vinegar. And sometimes we use, or I have been using over many years, a weak vinegar solution to irrigate the bladder. So just bear that in mind. That's what's really important. And I'll come back to that in the next slide. So there is your acidic area, there's your neutral area, and that was your alkaline area. Sorry, yeah. Next slide, please. So you want to very simply and easily try and keep your urine as acidic, that is a low pH, as often as you can for as much time as you can. Please, please, if you have a bladder that has to have a method to empty it, you must never use citrus soda, however much discomfort you have, because that is very alkaline. And it actually doesn't react well with microdocs, I've heard as well. Now, you can get vitamin C in your diet. Lots of tomatoes, oranges, red and green peppers, broccoli, strawberries, melon, and potatoes. I'm sure most of us will eat the majority of those fruits and vegetables. You can spend more money from getting vitamin C from cranberry, either as dried cranberries or juice or tablets. Be careful, they're expensive. And be careful if you buy the juice, it has to be the pure cranberry juice, which is costly. So in my opinion, not really worth it. It's much cheaper to grab a big bottle of vitamin C tablets, and you can take up to 2 grams a day. The nice thing about vitamin C is it's excreted in your urine, so it really keeps your urine nice and acidic. And Dr. Van Beek will probably say, but there's no real evidence for this. I agree, but it's anecdotal, and there is some evidence. And you know what? Vitamin C in large doses actually doesn't harm anybody. Next slide. So this is the most important slide of the whole presentation. As Ari has alluded to, having a spinal cord injury or a neurogenic bladder for any other reason is very hard work. You can't get up and walk to the loo and take a pee. You can't do this spontaneously. Everything about your bladder and your bowel management has to be routine. And routine is so critical. And if you don't establish that routine in the early days, it can obviously change with time, but establish a routine, you're going to be in trouble, definitely. And I see this time and time again. Patients who are struggling don't have a good routine. So that glass of water is your biggest friend. Water can become boring. Put things in it. In your bottle, put lemon slices, put strawberry slices, put cucumber slices, put fresh mint. Be creative. At the end of the day, you can even add a little bit of something if you really want to, if you've had a bad day, but that's not the best thing to do. So focus on your routine. Next slide. So I am on the subject of fluids. I've ticked water. Please try and avoid fruit juice. It's just useless calories and a lot of sugar. Don't drink fizzy drinks because that fizziness is actually not very good for your gut at all, makes too much gas. And alcohol, some people do drink it, obviously, but please keep it to a minimum. Try and restrict your alcohol. And my advice to every patient now is drink a minimum of 2 liters of water from the time you wake up to the early evening. And then only drink if you're thirsty, because when human beings lie down and drift off into beautiful sleep, our pulse goes down, our blood pressure goes down, therefore less blood is going to our kidneys, so they make less urine under normal circumstances. You don't want to make large quantities of urine at night. It can disturb your sleep because you have to either catheterize or somebody has to come and empty your your catheter bag. So only drink at night if you're really thirsty. And something I only learned recently from one of the congresses I went to was that apparently black tea you shouldn't drink too much of it because it can help you make bladder or kidney stones, and then you'll need Dr. Van Veek's help. Next slide, please. So it was mentioned earlier that Lindsay spoke about a biofilm, and I think it's just important so that you understand exactly what it is. It's a layer of bacteria or other microbes, for example, fungi or viruses, that can grow on and stick to the surface of a structure. So if you've been lazy and you haven't brushed your teeth for 24, 48 hours, you will feel that kind of sliminess on your teeth. So it can cover natural surfaces like your teeth, but it can also, the bacteria also grow in or on medical devices such as catheters or even artificial joints. And if you have chronic infections, it's definitely linked to decreased immune system response and the big word, antibiotic resistance, persistent inflammation, tissue damage, and a real problem for diagnosis. So the biofilm is really, really a huge problem, particularly in neurogenic bladder. Next slide, please. So why did I start using microdocs? A bit like Ari, I was introduced to it by the urologist who does all the urodynamic studies for my patients. And frankly, antibiotic resistance is really scary. Funnily enough, I had a brief social meeting with a senior microbiologist colleague of mine today, and we discussed this briefly, and she didn't know about microdocs, so I'll introduce her to it so she doesn't need it herself, but at least she needs to know about it in her practice, because we again agreed that it's one of the most scary things in the medical world is the way antibiotics are not working the way they used to. So I always say to my patients, they've got a bacterial stew in their urine, and that is normal. The bacteria are hanging around there. You can't get rid of them 100%, but certainly when I got introduced to microdocs, I thought, gosh, this is a good thing. My colleague has recommended, let me try it. I checked up the clinical evidence and it was compelling. And I put the last point in green because it's safe, it's easy, and it's cost effective. And I think something nobody's actually said, you can chuck it down the loo or in the drain. Next slide, please. After you've used it. So it's simple to use. As Ari said, it's really straightforward. The primary thing is wash your hands. Please rather wash your hands than use gloves. You have no idea where your gloves have been. You empty your bladder. If you have a you can use a 30 mL via a catheter tip syringe, and you must insert the microdocs and leave it for not more than 15 minutes. And you can repeat it again if you've got a lot of sediment, which some people don't know what it looks like, but it's like small pieces of sand or gravel or fluff. And actually you can warm it, I believe, up to 40 degrees centigrade if it's more comfortable for you, because some people do have some degree of sensation, and a cold dose of microdocs may be rather unpleasant. And don't forget, if you are on antibiotics, for whatever reason, it's still safe to use microdocs. Next slide, please. So how often? Ari mentioned it, you do a maintenance. You can do it once per week or twice per week or 3 times a week. It just really depends on what you feel is best for you. If you suspect you're developing an infection, use it twice daily for 3 days until you feel better. You can carry on, then go on to your maintenance after that. You can't harm yourself by using it as you feel it's best for you. And if in doubt, put your hand up and ask. There's always somebody available to answer your question. Next slide. So this to me is what's important. I've got 2 particular patients. One is a paraplegic, the other is quadriplegic. And Mr. C, he was such a problem, 8 to 10 infections each year. Difficult funder. You know, his medical savings usually ran out 2/3 of the way through the year. Sometimes he had to be admitted. He had to have multiple occasions off work. He got really depressed and despondent, and he was a hard worker. He was a diligent employee in his company. And really, with use of Microdox in the last year, if he's had one infection, it's a lot. It has changed his life dramatically. And Ms. M, she's quadriplegic. She has a suprapubic catheter. She has sufficient hand function to change it herself. And she's had years of frequent infections with the way that her infections present are with increased spasms. And she even feels those spasms in her bladder. And I happened to talk to her just in the last few days after I'd done the slides myself. And I said, how's it going with the Microdox? She said, you cannot believe it. If my bladder starts to feel twitchy, I just increase the dose and it goes away. She said, I'm like a new person. That's exactly her words. She hasn't required antibiotics for 6 months, which has been amazing. So really, in summary, both these patients, and it's just 2 of my patients, are very positive with their experience of Microdox. Now, I haven't got another slide. I think that's my last slide. I just wanted to mention everybody's got a different funder. Some people pay for the Microdox themselves, and unfortunately, it's reasonably affordable. I deal with a lot of patients who are injured on duty, and I have started prescribing Microdox because the pharmacy they use had run out of the acetic acid, which is a weak vinegar solution. And they are certainly putting it on the patient's scripts, or rather I'm putting it on and they're approving it. So I'm going to keep pursuing and putting all my patients onto Microdox, because I think the aim in my mind is to keep patients healthy and keep them out of hospital as much as possible. Most of the medical aid so far, I haven't had problems with. I anticipate problems with the Road Accident Fund, and Ari knows exactly we've been corresponding about a recent problem with intermittent catheters and the Road Accident Funds. So Ari, we might have a fight on our hands with Microdox, but let's give it a go. And that's the end of my talk. Thank you very much for listening.
Thank you so much, Dr. Wilson. That was a huge amount of valuable advice and information for everybody. Much appreciated. I'll continue on, if I can have the next slide, and introduce our last speaker tonight. Last but not least, Dr. van Wyk. Dr. van Wyk is a urologist at the Pretoria Urology Hospital. I've really had the pleasure of working with Dr. van Wyk now for almost 30 years, Dr. van Wyk. He specializes in female and male pelvic floor medicine and has a special interest in prostheses in urology as well. He started the Pelvic Floor Center at Urology Hospital almost 3 years ago, and Dr. van Wyk consults to Steve Biko Hospital and is very actively involved in urology training in South Africa, which is fantastic. So I'll hand over to Dr. van Wyk. Perhaps the next slide, please, Dylan. Dr. van Wyk, would you like to put your video on? Perfect.
Am I on, Lindsay?
Yes, you're on, Dr. van Wyk.
Okay. Thanks,
Thank you.
Lindsay, for your initiative, and thanks for the talks, Virginia and Ari. That was great, and welcome to all the participants that's listening. I might take a little bit different tact on the use of Microdox, just in my personal experience and where I think the place is. I think Microdox is definitely something that's evolving in where we're going to use it, and for which patients it's going to work best. We don't know that yet, but I think it's safe, and we can start using it on more patients and try to learn where it's going to work in your practice or for you as a patient. I know that we are a mixed audience, so I will try not to do too much information in scientific information. So I'll try and keep it a little bit more practical. This is just a picture of my daughter and myself. After she saw me operating, she decided that radiology is probably a better discipline to go into. So unfortunately, she's not a urologist. Next slide, please. So where do I see we can use microdocs as an installation or a bladder wash in? The first one is to use it for indwelling catheters. So patients, and we have some elderly patients that's incontinent, or they got incomplete bladder emptying, and they can't use intermittent catheterization, and they've got either suprapubic or urethral catheters. Then the other group is those patients that do clean intermittent catheterization. And then the third group is the patients that I would say that we're going to put in a catheter to treat an acute infection. And there are two subgroups of that. I've got some difficult patients that presents with infections, and then I would put in a catheter, leave it in for 5 days, have them put in they can't self-catheterize, put in their microdocs twice daily until the infection is cleared, and then we take the catheter out again. And also for patients that has to go for operations where there's a high risk for infection, like in knee and hip replacements. Sometimes they come in with a chronic infection and it's difficult to get rid of that. And we put in a catheter and leave it in for a couple of days, wash their bladders and get their bladders clean so that they can go for the operation. The occasional self-catheterization is a subgroup of patients that we might in future use, and those are the patients that do get simple urinary tract infections and they don't want to take antibiotics, and they can just maybe we can teach them how to put in a catheter, do the installation as soon as they have symptoms, and not use antibiotics. Next slide, please. So what conditions do we normally treat? Is the neurogenic bladders, that's the biggest group. And then there's patients who we create a new bladder after removal of the bladder, like for bladder cancer, or we enlarge the bladder for augmentation in patients who've got small shrunken bladders, and in patients that we do continent diversion. So we make a stoma that is not an incontinent stoma. They have to catheterize through the stoma, and they've got a reservoir intra-abdominally that's made of bowel. So that subgroup of patients, we also need to sterilize the pouch or the new bladder. And then, as I said, we can use it for pre-op preparation, patients who has got recurrent infections, patients with uncomplicated urinary tract infections that can use it as a single or a twice daily dose till they symptom free. And then in patients that we need to put on prophylactic treatment where they will go for a procedure and we have to get them clean. Next one. So what are the main health risks for spinal cord injury patients? Remember that morbidity and mortality is mostly caused by respiratory complications, cardiovascular complications, and a big group is the urinary tract infections, as well as septicemia leading from a urinary tract infection. We know that pressure ulcers, DVTs, and there's many psychological factors, and also then the secondary complications of pain, spasms, osteoporosis, and gastrointestinal gut bowel problems in the spinal cord injury. But the third biggest group is the patients who's got urinary tract infections and sepsis. Next one. So just a little bit on neurogenic bladders. And I think that's important for us to understand that the changes that happens with a neurogenic bladder is due to the fact that the bladder's function is not normal. So the bladder goes back into a reflex mechanism after the spinal cord is injured, and the bladder starts working autonomically. But the problem with that is that the sphincter mechanism, the control mechanism in the outflow, is sometimes not coordinated with a bladder contraction. So the bladder starts contracting against a closed sphincter mechanism, and then develops a high pressure system in the bladder. And that is bad for the function of the bladder. We also see kidney stones, and the loss of sensation in the spinal cord injury patient leads to the fact that they can't feel the bladder filling or emptying, so they're not aware of what happens in the lower urinary tract, and that can lead to overfilling of the bladder and all the complications thereof. And then there's some practical issues in timing of catheterization and also a good bowel program. Next one. So this is just a picture of what happens in the bladder, and you can see on the graph there, that is a urodynamic study. And the blue line is what happens inside the bladder. And you can see as we fill the bladder with fluid, there's a gradual increase in the bladder pressure. And that can go up to, in this case, up to about 100 centimeters of water. So the high pressures will cause reflux, so the urine will be pushed back into the kidney, and that will cause that the bladder infection can spread up to the kidney and cause kidney damage. The high pressure system in itself can also cause kidney damage. And normally we say that if the pressure goes up to more than 40 centimeters of water in a neurogenic bladder, that is dangerous. So we like to keep the pressures in the bladder low by giving medication. We try and prevent reflux, so we don't want to have vesico-ureteric reflux, where the urine will be pushed back into the kidney. And we need free drainage. So if we empty the bladder, we want to empty it completely, either with intermittent catheterization or sometimes with an indwelling catheter. And we want to decrease the risk for stones and crystallization. Next one. And then just on catheters, remember a foreign body inside the urinary tract will likely form crystallization and a biofilm, as we talked about already. So in the neurogenic patients, spontaneous voiding or a Credé maneuver where you press on the lower abdomen and empty your bladder is not a very good mechanism to empty your bladder, because it's not possible to empty the bladder completely, and there's always a residual volume. So clean intermittent catheterization is still the aim. Indwelling catheters helps us a lot in patients who can't catheterize, and the route of the catheter is important. So if you use a suprapubic or a urethral catheters, there are some complications with either one of the two, and it's important to have that discussion with your patient. But the crystallization in my practice in the patients that we replace suprapubic or urethral catheters from time to time has definitely decreased since we started using microdocs. So for those patients who has got an indwelling catheter, whether they're spinal cord injury patients or just patients who can't empty their bladders or are incontinent, we started giving them microdocs. And when you change the catheter after 2 or 3 months, there's very little crystallization, and also the risk of infections is much lower. Next one. So what is the problem? Why are we concerned about the infections? Next slide. And it is the risk for antibiotics resistance. And the problem is that the wide use of antibiotics in animals to help with their feeding, and they say by 2050, 10 million people will die per year due to drug resistance. It's very prevalent in Africa, and it's much more of a problem than even in the COVID years, the death rate. And the problem that we have is that we have patients who's got indwelling catheters or intermittent catheterization, and they get courses of antibiotics every 2 to 3 months. And then they become resistant because their gut flora will change due to the antibiotics. Next one. So the bacteria, remember, it's an organism with a cell membrane, and the pathogens in our that we carry with us is by far in the minority. We've got about 30 to 100 trillion organisms that we carry around, and we need those, mostly in the gut. And the pathogens can cause damage by direct infiltration into the tissues, produce toxins or enzymes, and cause an immune response. Remember, the size of the bacteria is normally about 1/10 of a normal cell. Next one. So biofilms, we talked about that. And we often find patients coming in and say, and you ask them, why do they think they've got a urinary tract infection? And they would say they see these little, the urine becomes a little bit milky, and there's these flaky deposits in their urine, and that's the biofilm that they pass out, and it packs on the bladder wall, and then as soon as you stop the antibiotics, it will start growing again. Next one. So normally you can colonize your urinary tract with infections, and it can spread from the kidneys down, it can spread through the bloodstream, it can spread from the bowel, and we talk about the leaky gut syndrome, where it perforates the large bowel, it gets into the lymphatic vessels and the blood vessels and go to the bladder. Next one. So what do we do in the urinary tract to prevent the infections? We use it as bladder installation. We wash patients with indwelling catheters, and in the resistant infections, we use that as a supplement to the antibiotic use. And then we break down the biofilm, and I use it post operations. We place prosthesis to prevent infections. And then there might be a place for simple urinary tract infections that patient can use that, but I'm not sure whether patients will do that and rather not take a short course of antibiotics. Next one. So I'm not going to say too much about the mechanism of action, but it is a normal molecule that our bodies produce and use for our immune system to fight bacteria. It perforates the cell walls, and it kills the bacteria. Next one. It is safe. It's been tested on animals as well as on humans, and the concentrations that we use to kill bacteria, it's much lower than the toxic concentrations that will irritate the tissues. Just a warning for if there's any doctors listening, if you do installations for patients who's got painful bladder syndromes or interstitial cystitis. Just be careful. Anything that causes the change in the pH can often irritate the bladders significantly. So just be careful if you do that. Next one. So at the moment, we're using 30 mils as a 10-minute installation for indwelling catheters, as well as for intermittent catheterization. In the acute treatment, we use it for 5 days. In the post-acute treatment, for another 5 days, just daily. And in prophylaxis, it is not certain how often to use it. I think that has to be decided on an individual case-to-case. Next one. So this is, in our practice, definitely a big help. We've got another tool that we can fight infections, especially in our patients who has got recurrent bladder infections, has got indwelling catheters, or does self-intermittent catheterization. So I think we will still learn a lot and see where that's going to work best. But for now, I think all patients that has got recurrent infections and physicians that treat them must be aware of this treatment. Thank you, Lindsay.
Thank you very much, Dr. van Wyk. Really appreciate your very, very interesting input. Dr. van Wyk uses a multitude of different products within this segment, so he's very kindly presented to other urologists as well on this technology. So thank you very much, Dr. van Wyk, again. Next slide, please, Dylan. And I think the next one. We have literally 3 minutes left, so I'd like to just briefly inform you of a few things. One is that I will tell you about where to get hold of Microdox and its family of products. And on that same website, you will also find and have access to the Coloplast 100% silicone catheters. There are 3 different tips, which is the open-ended, the closed-ended normal Foley, and then the curved one, which is called the Tiemann, which is very helpful, especially for men, to go around the curve of the male urethra. This is a product that is highly compatible to the tissue. Next slide, please. I'd like to thank Ari's organization, QASA, the Quad Para Association of South Africa, and I'd like to thank Rolling Inspirations, the magazine. Please keep your eyes open. We will be sending out more information in the next publication, the next quarterly publication. But I'd really like to thank the organization for working with us on this project and other projects that we plan in the future. We would like to bring you more webinars, possibly on other interesting subjects as well, but we'll notify you of that in due course. Next slide, please. The question that I think everybody will ask is, where do we get hold of Microdox and the Microdicin products, the solution and the gel? Dis-Chem and Local Choice both stock the product. You may find that the Dis-Chem in your area doesn't have it on their shelf, but if you ask them to bring it in for you, they will certainly do that, and so will the Local Choice. Next slide, please, Dylan. So please, if you'd like to place your orders, let us know. You'll find that there's a coupon, a code that you can put into your purchase. Next slide, please. Before the Q&As, if you will bear with me very, very briefly, I've had a direct request to just go through the usage of Microdox, if people can just bear with me. So Microdox comes in a 500 milliliter container. Thank you very much, Dylan. It comes in a 500 milliliter container. It does not need to be diluted. It gets used exactly as it is. And the intention of Microdox is to rinse the bladder. So the suggestion is that Microdox can be used in an acute situation, 30 mils twice a day and left in the bladder for 15 minutes. So you can use a catheter syringe, pull your Microdox up, put it into your bladder and clamp your bladder, leave it in for 15 minutes. If you have a catheter in, you can just put it through the catheter and rinse it, let it sit, and then let it drain out. So the suggestion is that you use it twice a day, 30 ml twice a day, for at least a week in an acute situation. Then the following week, you do it once a day, and the following week, you can go into maintenance. Maintenance, it's your decision. A lot of people use it once a week, and some people use it more often than that. If you do not use a catheter and you have a functional sphincter, we do have a little device on our website called a uroadapter, and it is used for just the